Hi, I'm Sue Luff. I'm the Head of Commissioning for Ashford CCG. So East Kent has 4 CCGs, and it's important to know the geography. So we're surrounded by sea on 3 sides. We're really got a monopoly provider situation at the moment. So just bear that in mind when we go on. So we've really sort of spent the last year trying to build a framework for our vision for urgent care and community services, and what we've started doing is putting things in place. We've got integrated teams in place, we've got a local referral unit, we've started doing 7-day primary care in one of our clusters, and that team then works with the intermediate care team at weekends for discharges and so on and so forth. We've put a community geriatrician in and done lots of work around the care homes, and that's been really successful. We've got, like I say, a care plan, hopefully, that we're about to launch in June, that will link into our ambulance service, acute care, and so forth. And I would say that without doubt, we've done that with partnership with Kent County Council, and that's proved to be sort of really successful. I think our biggest challenges would be that we have got one provider in East Kent for our secondary care. We're very limited where else to go, and sometimes there is sort of competing strategies. So our strategy that we build these community hubs and these community networks doesn't always fit with the way that the acute trust wants to go, because obviously they'll lose a significant amount of income and activity. And the way we've tackled that really is by having a sort of sensible conversation about we're in this together, and this is about the health economy. And actually, if we can create that capacity, that then allows us to bring some of the work back that we currently send to London and repatriate a lot of that work, that thing. So there's benefits for all organisations. I think the biggest thing at the moment with our providers is our relationship between our secondary care and our community is been quite strained at times. And because of that, we end up getting involved in operational issues. So I'll give you an example of that, the management of the delayed transfers of care. The commissioning team were asked to go into the secondary care and lead some of those CTOP meetings to try and focus them and challenge each of the providers. And so I've been doing that at one of the sites, and that's been quite, we can't carry on with that because we haven't got the capacity, and we shouldn't have to do that, because they should be provided that function. I would say our other things, I've spoken about primary care and their capacity. The other thing I would say around primary care and general workforce is that we all know where we're going with better care funding and the pioneer and so on and so forth. And I suppose what I would like to see is some of those national bodies starting to think about workforce changes and putting them into place now rather than sort of 3 years hence. So we're starting to grow the skills that we need and the workforce that we need sooner rather than later. In tracting and procurement, we've actually put in some joint sequins this year across the providers to really try and force them to start working together. So we've got over 75 one, we've got a pulmonary rehab one, and so on. We're also a pioneer site, and that's great. Really positive, really committed. Everybody wants to go in the right way. I would say one of our challenges has been our local council. I mean, they're very keen and they absolutely want to work with us, but sometimes they do go off at a little bit of a tangent, and it goes away from the strategic vision of their own county council sometimes. We have done a lot of work around our population growth with our local council, because Ashford as a town is set to have a 40% increase in population over the next 5 years. There's huge housing developments going on. So there has been, we're not there yet, we haven't got the exact detail yet, but we have started that work about mapping out what will the future of healthcare look like, so we can make sure that we've got the infrastructure there to support it, when all these things are up and built. So I know time's going on, so that's just it really for me. And voluntary agencies, we, again, like yourselves, have done a lot of work with voluntary agencies. We've put in a grant system where they can apply to us for grants, and then if it fits with the strategic sort of need, that's what we'll do. I would say some of our smaller voluntary agencies are struggling really they haven't sort of the capacity and trying to get their heads around the new way of commissioning and the new way of contracting for them. It's been really difficult, and I wouldn't say that some of the national agencies sometimes support them. So if you look at Age UK locally, very keen to get on and work with us, but they really get very little guidance from their national body, and so how do we try and support them in that process? And that's it from me.
Okay, thank you, Sue. I think we have got Roland Scanlon with us from Monitor. I can't see you, Roland, but can you hear us?
Yes, I can. Sorry, I had a few technical difficulties, so I've been eagerly listening in the background.
That's great. Well, I'm sorry not to bring you in earlier. It's very good that you can be with us. I wondered, do you have any questions for Sue? And I wondered whether or not anyway, so do you have any questions for Sue, first of all?
Yeah, sure. I mean, it's obviously really interesting from Monitor's perspective to hear about the different ways in which, you're each moving forward the integrated care agenda. I suppose you mentioned, Sue, the use of joint sequence just briefly, and perhaps in relation to trying to force the different providers to work together. I was wondering if perhaps you could say a little bit more about that. And just separately as well, I was listening keenly to the last speaker with regard to the use of Health Watch and perhaps some involvement with health and well-being boards. And we're interested to see, and I think there is some variation between the different commissioning areas in how proactive those two organisations are, and whether you're able to get useful data or useful feedback from them, which helps kind of inform and sort of fortify support for these different approaches. So I'd be interested to know what your experience was, if any, with those organisations as well.
Okay, so the joint sequence, if we take the over 75 ones, it says we actually have a clinical forum which consists of consultants and GPs and the chief nurses from the organisations, and they met to determine what clinical outcomes we wanted for over 75s across the health economy, and really that was then so that's how we're going to measure people performing against that sort of sequence. But the sequence we're all about for over 75s, the integration was around. So if we're going to say that we're going to affect early discharge and start using the integrated care teams and use the voluntary agencies, if one organisation is achieving and the other one isn't, what we can't have, historically they've done is they've blamed each other. They've got to work together to sort that problem out. If we go back to the detox, for example, is my exit strategy is in 2 weeks' time. I'm not going to go to their operational meetings anymore. They have to work together to sort that process out, because we can't keep getting involved in them. So I wouldn't say we're quite there with them yet. I wouldn't say the providers actually fully understand them yet, but we're a much better place than we were 6 months ago. In terms of the Health and Wellbeing Board, then what I would say is the overarching Kent one, very organised, just about to launch their strategy, just about to go out and do a joint communication exercise. I'll say the Ashford one, which obviously feeds into the Kent one, has had a few teething problems, and I think, to be fair to them, it was because of the borough council dynamic. The borough council really sort of took that over and just went off a tangent with their own agenda and not, what was needed for the health needs of the local population. So we've just really in the last week agreed a work programme with them, but it has taken all this time to do that. Health Watch really isn't very proactive in our area, which is a little bit of a problem. And our lay members for engagement are working with them to try and get them more proactive and try and get them more involved with us. But we do have a very sort of vocal patient participation group that feeds into them, and that's really been our route into them.
That's really interesting. Thank you.
So I was wondering if you could say a little bit more about your engagement with your local secondary care provider. You talked about having the 3 CCGs having one large provider in East Kent. How, at what levels have you had that engagement, that conversation with the hospital? To what extent have you tried to align vision and values across all the partners involved, or if you had to accept that there are differences that are irreconcilable?
Okay. So, I mean, the engagement happens at sort of many levels. Obviously, you know, there's the usual board-to-boards and meetings. I mean, we've invested a lot of time going, bringing the two teams together and physically going into the on-site, talking to people. Really, for us, it's just about, we've used the contract for this year to say, you know, let's be sensitive. It's not a block, it's sort of cap and collar approach, just to get an agreement over the contract to say, you know, let's not be arguing about tariffs and contracting issues for the next 2 years, because we really need to work together to implement some of these pathways once and for all. So you know what happens, sometimes you want to put a pathway in place and you get into a discussion with providers about we can't do that because we're going to be losing income. So let's stop that argument, let's sort the contract out, and then that then gives us the time and the space to do the work that we need to do to work together to change things. So we've spent a lot of time getting the providers together to really talk about our vision, what is it we want to do. I would say for our urgent care, we absolutely have a shared vision. Everyone agrees that what we want is the front end of urgent care is to be primary care led, and we've tried. We've had a GP in A&E for working for the past year. That's been really successful. We're going to build on that now and you know, put a more integrated team in there. So secondary care, absolutely on board with that. And I said before, the way we've used that is because really then just, you know, nurturing them through that process to say the benefit for them will be is that their clinicians will have the capacity to then deal with the cases that they actually need to deal with, and not the cases which are really primary care cases. So yes, they will be losing urgent care activity, but actually they can manage the trauma better. They can sort out some of their surgical issues, you know, in a much more sort of cohesive way, and they can start bringing some of the work back from London. So they've got capacity and finance, you know, coming back to them. Sorry, I forgot what the second point of your question was.
I think you've addressed it. I think that's fine.
Okay.
Can we go to Jay now? Do you have any questions for Sue, please?
In terms of moving forward, in terms of integration as such, do you think you'll ever get to the point where you'll completely, you know, use the budgets as a pooled resource, or do you think there'll still be some separation for the integration or for the integration agenda? Because I know that the BCF talks about pooled budgets as such, but you do wonder if it needs to go much further to really encourage integration. Do you have any views on that?
Yeah, I mean, I think what we feel is we need to really sort of have joint commissioning, have one commissioning team, and that's really the way to drive it forward. We have done some work with the Commissioning Academy, who they were in a sort of small course a few years ago and did that, and that really sort of helped us to open our eyes up into, you know, the possibilities of joint commissioning. I mean, Paula, who was my colleague that was going to join the meeting, she's a commissioner in cases in Kent County Council, and really at the moment I would say we're joined at the hip, but we are still two different organisations. What we need to start doing is actually just having, you know, one team, one organisation, and a bit more joined up. I would say we're a bit more advanced in some areas. Certainly we've spoken about it with children's commissioning and with mental health commissioning. And I think with children's we probably will get there in, you know, this year at some point. But full budget's fine, but it's the commissioning bit that will work.
Okay, thank you.
Thank you, Nick. What are your thoughts and reflections for having heard Sue talk about what's going on in
Yeah, it was very interesting actually. I think there were a couple of observations that I had, and I think, you know, I asked Jay the question about capacity review and how the HR are reflecting upon the demands over the future. And I think you've probably got in Kent, particularly in the areas of Ashford, even more of an acute problem, haven't you? Because there is such exponential growth in the population, and it's all, it's infrastructure development. So I think that there's a question about there for you, for me, sorry, about that. But the other thing, I think one of the themes that it strikes me about integration is that it's and you touched on it a little bit in the presentation in workforce development, is it's about behavioural change. And one way to, from my perspective and my experience, one way to deliver integration and to actually make it real is to inform and deliver behavioural change across the workforce. So I was interested in, more so than the population one, but I was interested in just understanding where you are with that.
Well, I'd say, where we are with that. We've had some successes and we've had some disasters. Our successes have absolutely been getting the people on the shop floor working together. I mean, I'm a sort of great believer in, actually, if you get those people, in a room working together, by default they'll start solving the problems out themselves without anybody from on high doing it for them. So that's been good for us, because we've got the social care teams and the integrated teams and the district nurses teams all in one room working together, and they've really driven that process themselves, and really that's been much better than trying to get sort of a group of senior managers in the room and sort of integrated. So I think that's really our lesson, is that just trying to empower those people that are actually delivering some of that work to take something forward. So example we had the other day is in one of our community hospitals is rather than me going in and dictating what the specification will be like, it's just saying, well, this is the remit, work it out yourselves, I'll come back in a month and you tell me how it's going to happen. And they really rise to that challenge, I think. On the other hand is, not all teams are like that. Some of them are, a little bit suspicious, what you're doing, a little bit, it's just taking that leap of faith, isn't it? And I think we need to nudge them through that process.